about 5 minutes. Hello, everybody. Can everybody hear me? Hello? Hello? Welcome, everybody.
Hello.
Everyone?
Test 1, 2.
Program is going to start in 1 minute. If everybody can start finding their seats. Thank you.
That one, yeah.
Okay, good. If everybody could go start finding their seats. Everybody get last drinks and go sit. Thank you. Hello, everybody. Can everybody hear me all right? Yes? Welcome to Northeastern University. My name is Leslie Sykes, and I'm the Director of Strategic Partnerships for Northeastern University's Charlotte campus. It's an honor to be here with you all today at the first event hosted by the Masters of Public Health program, and I'm excited to see so many of you gathered for such an important conversation. The focus on social determinants of health is incredibly relevant, and particularly here in North Carolina, where these factors significantly shape the health and well-being of our communities. As the Director of Strategic Partnerships, I've seen firsthand the power of collaboration and how crucial it is to bring together experts, organizations, and individuals to tackle complex public health challenges. Today's event exemplifies the spirit of collaboration, and I'm proud to be a part of an institution that understands the importance of fostering these connections. I would like to thank our esteemed panel of public health experts and the Deputy Director of Health and Human Service for being here today to share their knowledge and experience. Their insights are invaluable, and I'm sure we'll leave here with a deeper understanding of how social determinants of health impact our communities and what steps we can take to address them. This event also highlights the crucial role of our Masters of Public Health program plays in training the next generation of public health leaders. By engaging in conversations like these, we empower our students to be agents of change, equipped with skills, knowledge, and partnerships needed to improve public health outcomes, both locally and globally. I look forward to the discussions we'll have today and continued opportunities to work together in driving solutions that improve the health of our communities. Thank you to everyone who has made today possible, and to all of you for being here and engaging with this vital work. Thank you, and now I'd like to introduce Rob Lehman, Professor and Chair of the Department of Public Health and Health Sciences. Welcome, Rob.
Thank you so much, Leslie. Thanks all of you for being here. Greetings from Boston. I am, as Leslie said, Rob Lehman, Professor and Chair in the Department of Public Health and Health Sciences at Northeastern. I have the privilege to lead our large multidisciplinary department. Even though we are a department, not a school or a college of public health, we really have all of the areas of expertise you would expect in a department or in a school or a college of public health, including biostatistics, epidemiology, environmental health, global health. The list goes on and on. So privileged to be here tonight and appreciate the warm welcome tonight. And previously, we've been part of a number of wonderful events here at the Charlotte campus, most recently the Heart of Charlotte Awards. So now that we have launched our MPH here in Charlotte last academic year, and that's established, we're thrilled to be hosting our first event, Northeastern Public Health here in Charlotte. And thinking about the topics that we could address in this event, we thought of no topic more pertinent, more important, more timely than the social determinants of health. And to make that possible, thrilled to have our panel, our esteemed panel here, and can't wait to hear their insights. I want to give a couple of other thank yous. I want to thank Allison Hudson, our staff member here in Charlotte. She did a tremendous job. There's always a certain amount of both excitement, but I'll be honest, a little bit of anxiety, and putting an event like this together, having someone like Allison on ground, it takes that anxiety way down. So appreciate that a great deal. And I would be remiss, I love the expression, I would be remiss, so it gives me a chance to use that, but I would be remiss if I didn't mention the presence of a very important person here tonight, former Director of Public Health in Mecklenburg County, Gibby Harris, our sadly, I've made a change in my life where now I just advance my needs, and when a colleague moves on to bigger and better, I just lead with my disappointment. I don't know if that makes me a bad person, but so be it. So Gibby did move on to fourth retirement, Gibby, I think you explained to us, but many of us wouldn't truly, it's not an exaggeration to say that many of us would not be here if it weren't for Gibby and her efforts to put us on the map here, begin the process of putting us on the map here in Charlotte. So we can't thank you enough, and so pleased to see you here tonight. So to move things forward and get us one step closer to that outstanding expertise in the social determinants of health, I'm going to introduce my colleague from Boston, Dr. Neil Maniar, Professor of the Practice and Director of our MPH program.
Thank you, Rob, and welcome everyone. I do want to take a moment to just note the fact that I believe it was 80 degrees here yesterday, and it is 50 degrees today. And I just want to make it clear that has nothing to do with the fact that several of us came down from Boston. As we say in public health, correlation is not causation. Welcome everyone. It is such a pleasure to be here. It's always such a joy to get to come down to Charlotte and to get to be with good friends and to get to make a lot of new friends, and to see how the public health program is continuing to grow and thrive, and see how we build partnerships. as many of you know, we're in such a critical time for public health right now. And it is becoming more and more critical by the day. The needs that existed last year, last week, last month, continue to require our attention. But we know that there are challenges that lie ahead and challenges that require all of us to come together. And that's one of the messages that we continue to give to our students when we have, when they ask, what do we do? What is our call to action during this time? And we say that the call to action is the same as it has always been in public health. We will come together, we will collaborate, we will advocate, we will educate. And that is what we are hoping for this evening, as well as we have this wonderful conversation around social determinants of health and really, get to hear from experts in this field. So before I introduce the panel members, just want to go over the agenda a little bit. I'll introduce the panel members, and then we'll hear a State of North Carolina presentation, which will be wonderful. And then following that, we will have a panel discussion. And then that will also be open to all of you to ask questions to our panel members. Please continue to help yourself to the appetizers and to the drinks. And we hope to, we look forward to a really enjoyable evening. So without further ado, it's truly a pleasure to get to introduce this amazing panel. The first panel member is Dr. Ronnie Bell. Ronnie Bell is the Fred Eshelman Professor and Chair of the Division of Pharmaceutical Outcomes and Policy at the Eshelman School of Pharmacy at the University of North Carolina at Chapel Hill. Dr. Bell is also an Associate Director of Cancer Care Access and Excellence for the UNC Lineberger Comprehensive Cancer Center. Dr. Bell received his undergraduate degree in public health nutrition from the University of North Carolina at Chapel Hill in public health, and his master's and doctorate in foods and nutrition from the University of North Carolina at Greensboro. Dr. Bell completed a postdoc fellowship in gerontology and completed a master's in epidemiology from Wake Forest University School of Medicine. Dr. Bell is a native of Pembroke, North Carolina, and is an enrolled member of the Lumbee tribe of Eastern North Carolina. His research focuses on understanding and addressing disparities in chronic diseases in underserved populations, with an emphasis on rural and American Indian communities. He currently serves as chair of the North Carolina Health Advisory Council and the U.S. Advisory Committee on Minority Health. He co-leads the Southeastern American Indian Cancer Health Equity Partnership, a collaboration between the community outreach and engagement programs at the 3 NCI-designated comprehensive cancer centers in North Carolina. He currently serves as editor-in-chief for the North Carolina Medical Journal. He previously served as co-chair of the Healthy North Carolina 2030 Task Force. Dr. Bell, welcome. Dr. Sean Mohammed is a clinical professor in the Department of Public Health and Health Sciences and is the Assistant Dean for Student Belonging at the Bouvet College of Health Sciences at Northeastern University. Dr. Mohammed is the founding director of the Master of Public Health program, and from 2007 to 2017, oversaw the program in areas of education policy development, curricular design, public health workforce development, and recruitment and outreach to public health professionals. He currently serves as chair of the Education Advisory Committee with the Association of Schools and Programs in Public Health. Dr. Mohammed served as national co-chair of the expert panel on transformative educational models and pedagogy with the ASPPH Framing the Future Education of Public Health 2030 initiative. He is a lead accreditation site visitor with the Council on Education for Public Health and consults with public health programs seeking accreditation and reaccreditation. Dr. Mohammed is a board-certified family medicine physician and a fellow of the American Association of Family Physicians. Before joining Northeastern in 2007, he held appointments in the Department of Family Medicine and the Department of Epidemiology and Biostatistics in the School of Medicine at Case Western Reserve University in Cleveland, Ohio. You may also know Dr. Mohammed by his face being on the side of the trains here in Charlotte for our public health program here. No comment. Stacy Turpin-Saunders serves as the Deputy Director for North Carolina Department of Health and Human Services, Division of Public Health, and Section Chief of the Local and Community Support Section. She joined in North Carolina Department of Health and Human Services, Department of Public Health in January 2023. Prior to her service with the North Carolina Department of Public Health, Stacy served in the North Carolina Local Public Health since 2007, including as a local health, first in Alamance County and then in Buncombe County. I will pronounce that right one of these times. She has been a member of various state, regional, and local boards, advisory councils, and work groups, including as a steering committee member of the North Carolina Institute of Medicine Future of Local Public Health Task Force. She received a Bachelor's of Science in Medical Technology with a minor in chemistry from Radford University and holds a Master of Public Health from Johns Hopkins Bloomberg School of Public Health. So welcome to our panel members. So please join, or actually, Ms. Saunders, please come up to stage. Yes.
Great. Well, first you have me, and then we'll get to the panel. And so thank you all so much. I am honored to be here with you tonight. I've been asked to provide a bit of foundation on where we are in terms of public health in North Carolina. That could take days, even a whole semester, as many of you are aware, as you are studying public health now. But in the next 20 minutes or so, I won't be able to cover it all, but I do hope to provide an overview of our public health system in North Carolina for those of you who are not familiar, share that health is impacted by factors beyond just our bodies, highlight a few of the 21 health indicators that help drive my work and the work of others here in North Carolina, and emphasize the importance of the public health workforce. So let's first start with understanding the public health system here in North Carolina. Governmental public health in North Carolina is a decentralized system. And what that means is there's a state governmental system and there is a local governmental system that work together to protect public health. The state health department is a division within the North Carolina Department of Health and Human Services. That's where I work. And each county is also responsible for providing public health at the local level. I know there's a local health director in here somewhere. And we have 86 local health departments serving all 100 counties in North Carolina. The State Division of Public Health provides funding, guidance, policy, program requirements, technical assistance, so on. While the local health departments implement the programs and actually serve in the communities. Some of those programs are required by North Carolina statutes, and others are very specific to the needs of the communities in which they serve. And the state and local health departments are then a part of a much larger public health system. And that larger public health system, as you all are aware of, includes governmental public health, but also includes hospitals and community health centers and schools and nonprofits, other governmental agencies, and a myriad of others as indicated by that web of connection. In North Carolina, we utilize community health assessments, both at the state and the local level, to help identify health priorities and issues. For the state, the most current assessment is known as Healthy North Carolina 2030. In 2019, the North Carolina Institute of Medicine convened the 2030 task force to help create the assessment. And as it was mentioned earlier, and I think it's important to mention as well, my colleague tonight, Dr. Ronnie Bell, was co-chair of that effort. Healthy NC 2030, which I will often call during this H&C, is a set of health indicators with 10-year targets designed to guide the state's effort to improve health and well-being. It allows state public health, local public health, others in the larger public health system and beyond to work together on a shared goal. The major vision for H&C 2030 is to ensure that all North Carolinians have the opportunity for health. I won't spend, there we go. Not too much time on this, but the State Health Improvement Plan is the complement piece to HNC 2030, and that improvement plan helps create a unified strategy among the many stakeholders to drive improvement in the health priorities identified in HNC 2030. The plan identifies best practices that can help communities to improve health now. And we use that to monitor the 21 indicators through those strategies implemented and their impact. As mentioned, HNC 2030 helps us identify where to put our efforts in order to improve opportunities for health for our neighbors. In HNC 2030, it uses the County Health Rankings Population Health Model. This model identifies primary drivers of health and their proportional contribution to the overall health outcomes, like how long we might live and the quality of that life. In general, we tend to hear a lot about medical care here in the US. And research shows that much of our health is actually shaped by other social, environmental, economic, and behavioral issues. And those factors actually make up the majority. If you look over here, they actually make up about 80% when combined of the impact of our health. So we all know in this room that health begins in families and in communities and is largely determined by the social and economic context in which we grow up, in which we live, we learn, and we work. Our health behaviors, one of the other drivers, is made easier or harder by many of those social and economic factors. And then our physical environments, like the quality of our homes, the air we breathe, the water we drink, play a part in our health too. These three drivers, plus the medical care driver, all contribute to our health. For example, we can give a prescription for insulin to help a patient, right? The insulin is there to help control their diabetes. It is critical that that individual gets that medical care to help mitigate and control their condition. But if we send that same patient back to a world where they don't have stable housing, no sidewalks in their neighborhood, not a single grocery store, and they may have to get on 3 buses for about 2 hours just to make it to a doctor's appointment, we're less likely to see their health improve significantly because these other factors are also at play in their health. So tonight, I'll just be highlighting a few of the 21 indicators from the assessment that fall into those drivers of health buckets. I just wanted to note here, we won't spend too much time here, but the Department of Health and Human Services, in which the Division of Public Health lies, also has some focus areas, and these include behavioral health, child and family well-being, and then a strong workforce, which we'll talk about. So health, wealth, and education are tightly linked. Factors like education, employment, income, family and social support, and community safety provide the foundation for health and well-being. It's important that we start here. These social and economic factors drive all the other topics that I'll talk about and compound many of the other drivers. Income level is a strong predictor of a person's access to resources. Low income restricts the quality of housing, transportation, food, education, all which limit the opportunities for people to live healthy lives. Reading proficiency, which most people will say, wait, education is a public health issue? Yes, absolutely, because reading proficiency is a strong predictor of educational and other health-related outcomes. Our neighbors who are not achieving grade level reading by the end of 3rd grade are more likely to drop out of school before graduation, which can have lifelong economic consequences, including low-wage jobs and limited access to healthcare. These drivers of health directly affect our health outcomes, like the development of diseases we may have and our life expectancy, such that even in the same county, life expectancy may differ by several years in one zip code compared to another when they're only just a few miles apart. And over our history, the average life expectancy has steadily increased as we have made improvements in our healthcare, sanitation, reduction of infectious diseases, and improved safety measures. However, we've experienced a decrease in life expectancy. Recent overdose epidemics and the pandemic have left its toll on our collective life expectancy. And deaths associated with COVID and overdoses are impacted by where we live, how much money we make, our access to care, race, gender, and other factors. Over the last decade or more, we have seen that people living in poverty are at greater risk for fatal overdose. And during the COVID response, our Black and brown neighbors and our neighbors at lower income levels had higher case rates and were higher risk for death. Infant mortality is another key indicator of overall health of a population. For those who aren't aware, this is the death of a child before their first birthday. Both infant and maternal mortality are multifaceted problems. They are impacted by the same social and economic factors that we were just talking about, making it a sensitive indicator of a community's well-being. A high infant mortality rate may be a signal of further underlying issues within a population. And while North Carolina has seen improvements overall in infant mortality, and we've seen some closing of the gap in health, it remains that Black babies are 2 times more likely to die before their first birthday than white babies. Investment to further close this gap have included funds appropriated to communities with higher rates of infant deaths to support evidence-based programming and support services, including things like group prenatal care called Centering Pregnancy, found to reduce preterm birth and build social support among participants. It's also included supporting of doula services and promoting safe sleep education and programs where folks actually get safe sleep devices, and even providing transportation to support prenatal care and much more. About 30% of those 4 big drivers of the first couple of slides, about 30% of our health is influenced by our health behaviors. And as I mentioned, those social and economic drivers mentioned previously can help support or hinder those behaviors, like pregnancy intendedness. Unintended and or teen births are at higher risk for poor pregnancy and perinatal outcomes like preterm birth and low birth weight, which then in turn increases the risk of infant mortality. Currently, about 40% of North Carolina pregnancies are unintended. While births to teens 15 to 19 years old have steadily improved since about 2010, we are still quite a ways from that target that was set in HNC 2030. Increasing access to reproductive life planning, including access to contraceptives, is an important strategy for improving pregnancy intendedness. And on the other side of the slide, Session Law 2021-110 enabled pharmacist-initiated contraceptions. The Department of Health and Human Services worked collaboratively with providers and pharmacists, partners to develop temporary statewide standing orders. Then the Medical and Pharmacy Board adopted these standing orders as more permanent protocols. And then the North Carolina Association of Pharmacists then developed a hormonal contraceptive toolkit and training series. The School of Pharmacy at UNC received a grant to support the implementation of the pharmacist-provided contraceptive and hosted a summit in August of 2023 to launch this work. And at my last check, because of this work, pharmacies in 92 counties and 178 cities in North Carolina are participating and growing, meaning more access for folks to be able to plan their reproductive life. Though not included as a prime indicator in HNC 2030, rising rates of syphilis pose a threat to women and children. In the last decade, and hold on to your seats, in the last decade, there was a 538% increase in reported syphilis among women, with an associated 4,100% increase in congenital syphilis infections. To put this in historical context, in 2012, there was only 1 reported case of congenital syphilis. And congenital syphilis can cause miscarriages, lifelong medical issues, and infant deaths. And this is all preventable through supporting entry into prenatal care, early detection, and treatment of maternal infection during pregnancy. And North Carolina public health law requires healthcare providers to screen all pregnancies for syphilis at the first prenatal visit between 28 and 32 weeks of gestation and at delivery. Unfortunately, 43% of mothers with infants with congenital syphilis had little or no prenatal care. Additionally, while some women get routinely tested for STIs at their annual exam, men are far less likely to get routine screening. And so North Carolina has worked to increase awareness about this issue, including convening a Southeast Congenital Syphilis Payer Summit in 2023, releasing public health alerts and a media campaign about the issue, providing clinical training, expanded access to syphilis testing with rapid testing kits, and added Medicaid coverage for point-of-care rapid testing for syphilis and HIV. And as I'll talk about later, Medicaid expansion also means that more people have coverage for routine testing and treatment. Again, these are strategies that support policy that supports behaviors, allowing people to quickly get tested and get screened. Continuing with the driver of health behavior, let's take a look at drug use and overdoses in particular. Nearly 12 North Carolinians die each day from drug overdose. This epidemic has devastated families and communities throughout North Carolina and the entire United States. It is very likely that as you sit here with me tonight, that one of us in this room has been personally impacted or knows someone who has been impacted. And while prescription medications have been a major driver of the opioid epidemic, illicit drugs like heroin and synthetic fentanyl are increasingly contributing to the problem. The North Carolina Opioid Action Plan was released in June of 2017 with a collaboration of community partners to combat the opioid crisis. The plan was updated in 2019 and then again in 2021 and identifies feasible strategies to reduce overdose, including prevention, harm reduction, and connecting people to the care that they need. Additionally, North Carolina began receiving national opioid settlement funds in 2022. These funds are and will continue to bring desperately needed relief to communities throughout North Carolina who have been impacted by overdose. Often those affected are disproportionately experiencing homelessness, food insecurity, and may be unemployed or lack social support. And these funds have been used to support treatment, recovery, harm reduction, and other life-saving programs like post-overdose response teams and wraparound services in communities throughout the state. After years of state and local efforts, there is some optimism in that provisional data showing some improvement in this indicator. Our physical environment also plays an integral role as a driver of health. The quality of our homes, as well as the quality of our air and our water, even the presence of sidewalks, parks, and the proximity of healthy foods all impact the quality of our health. We spend a lot of time in our homes, and the health of our homes impacts the health of this body. Most homes built after 1978 have no lead paint in them. However, 15% of the homes in North Carolina were built before the 60s and may still have lead. Children in low-income families may be more likely to live in neighborhoods with older housing, which may contain lead. And in particular, children who are 6 years old and younger are more vulnerable to the effects of lead. Healthcare providers are encouraged to conduct lead testing on all children at 12 months and at 24 months. And children participating in Medicaid or WIC are required to receive those at 12 and 24 months. Children with elevated lead levels then receive home evaluations by public health. And because of these routine lead testing and evaluation efforts, North Carolina was recently able to identify lead exposure from fruit pouches. You all may have heard of this. That in turn resulted in the FDA recall of Wanabana fruit pouches. In addition, public health monitors and responds to other physical environment risks like hotter temperatures, rising sea levels, and air quality, and intense hurricanes. One particular example here is the heat health alert system. The impact of extreme heat can be harmful to our older populations and to those who have lung conditions like asthma and COPD. The alert system is supported by North Carolina Division of Public Health to send out heat alerts via email and often shared through various media outlets when the forecast is projected to reach unhealthy levels. This is important because it alerts not just the individual, but the communities about the need for support services like cooling stations or the distribution of fans. Lastly, I wanted to note the work that public health does in communicating the risk of environmental contaminants. In 2016, PFAS, a forever chemical, first came to our attention. And there are several communities in North Carolina where high levels of PFAS are known or suspected to be an issue. Since that time, public health, North Carolina DEQ, local health departments, academic partners, community organizations, and many others have been working together to respond to the community concerns, including the release of recommended limits on consumption of certain freshwater fish from the Middle and Lower Cape Fear regions, also known as the Fish Advisory. And now we've come to the final driver, that clinical and medical care. In the beginning, I talked about medical care tends to get a lot of attention when it comes to improving our health, and it can be influenced by some other drivers that we've discussed, like the social and economic factors. Increasing access is one way to help improve health. And in March of 2023, following the passage of House Bill 76, North Carolina worked to launch and implement Medicaid expansion, with implementation December of 2023. Many North Carolinians who did not qualify for health coverage through North Carolina Medicaid before, because they had made too much money, were now eligible for this health insurance. And this was a game changer, because while we might not have been able to change the social driver like income, we were like the amount of money somebody makes, we could change the medical care access lever by changing the eligibility. And in North Carolina, many of you in this room too were a part of this, quickly took action to automatically enroll nearly 300,000 people receiving Medicaid family planning benefits in December 2023 and move them to full health coverage. And at the close of 2024, 600,000 people had been enrolled in Medicaid expansion. As a result of Medicaid expansion federal signing bonus, North Carolina also made investments of about $835 million to support mental health and resources. So bringing our heads and our bodies back together, further supporting access to clinical care. This investment includes increasing reimbursement rates for behavioral health, improving the crisis system and continuum that you see here, and improving behavioral health for people involved in the justice system. This investment helps to continue building that comprehensive crisis continuum that includes someone to contact, someone to respond, and a safe place for help. So we spent some time talking about the indicators that are in HNC 2030 and how they relate to the drivers of health. As I begin to close out this presentation, I also wanted to note some emerging issues since the release of HNC 2030 that are rather timely as well. First, violence prevention, particularly firearms safety. North Carolina views violence as both a public health and a public safety issue, and both of those departments within the North Carolina government work together. The rate of firearm injury death in North Carolina is higher than it is in the US, with 17.4 deaths per 100,000 in North Carolina versus 14.7 deaths per 100,000 in the US. And child firearm deaths surpassed the number of child deaths from motor vehicle accidents for the first time in North Carolina in 2020 and remain the leading cause of child injury deaths. Efforts to reduce this violence have included safe storage devices distributed throughout the state, hospital and community violence intervention programs, suicide prevention, reentry services, and intimate partner violence programming. Additionally, public health must be nimble and prepared for emerging infections. And I wanted to note here that we've had a number of emerging infections over the last 2 decades in my time in public health. And in the news more recently, you've likely heard about avian flu, a disease that can affect most species of birds and mammals. And while we have found cases identified in birds and flocks in North Carolina, no human cases have been identified in North Carolina, though on January 6th, a patient in Louisiana died from highly pathogenic avian influenza H5N1. For the general population, the risk remains low for avian flu, and for those working in commercial poultry and those working with flocks, the risk may be a bit higher. And so Both state and local public health have worked to increase education and awareness, particularly to our poultry and commercial farm workers about how to reduce risk and identify symptoms for those working with poultry. And lastly, I wanted just to mention Hurricane Helene. In late September, Western North Carolina was hit by a catastrophic hurricane. Many of us were talking about that just earlier tonight. And Western North Carolina was left with significant flooding and damage, including public and private infrastructure impacts like water systems and roads. Several shelters were established throughout the region where local and state public health were coordinated, staffed, and supported. And hundreds of public health personnel were deployed from non-impacted local health departments and state health department to support shelters and environmental health needs. In order to help neighbors quickly disinfect their wells and sample their water for testing so that they could actually use it, state and local public health worked together and launched a direct-to-consumer well testing, well sampling initiative, getting thousands of well disinfecting and well sampling supplies out into the hands of private well owners easier and quicker, thereby improving the access. In addition, I just wanted to note that the North Carolina General Assembly appropriated $12 million in Helene recovery dollars to those impacted local health departments to restore their essential public health functions and serve their neighbors. I'm not going to go over this because I'm woefully out of time, but this is just a slide about the foundational public health service areas and the foundational capabilities. And those capabilities are those trainings and skills needed to support the public health services. And which gets me to this piece. I showed you all of that public health infrastructure stuff and talked about all of those different indicators, just to say that none of this work is possible without a capable and trained workforce. COVID-19 pandemic significantly impacted the public health workforce, leading to widespread burnout and staffing shortages. Our most recent PH Wins data, which is a national public health workforce survey, showed that 1/3 of state and local public health employees were considering leaving their organization, and only 5% of that could be accounted for by retirement. So for the students in the room, this is why you're very, very important to me today. In the last 2 years, at the Division of Public Health, we launched the We Are NC Public Health campaign, and the campaign has a twofold purpose, which is to, one, increase the awareness of careers in governmental public health, including jobs that are open right now in our state, and highlighted the essential role of public health and what it does every day for North Carolinians, so that folks know us better and see the work that we're doing for them. The campaign works to highlight the work that is happening each day, and we hope that everyone can see themselves in the work and want to explore public health. We do not have time to check out that video, but if you Google We Are NC Public Health, you can view that video yourself. And so in closing, I just want to thank you all. There you go. I just want to thank you all so much for the time you gave me tonight to talk a little bit about public health in a really broad way in North Carolina and how it is connected to those social drivers. I hope that you can see now that public health is working to serve and support you every day. And I hope that you can see beyond the symptoms of the person and look for the drivers that impact our wellness, mine, yours, and our neighbors, so that we can all improve the health in North Carolina. And so now I think I'm turning it back over to you.
Thank you, Stacy, for a wonderful overview of public health in North Carolina and for providing us with a great backdrop to the conversation that we're about to have. So I'd like to invite the panel members to the stage, please. Yeah, I'll sit up. We'll start off with a general question. Social determinants of health are often invisible, but pervasive in our everyday lives. From your respective fields, how would you define social determinants of health? And how do you see them affecting different communities in our society? So Dr. Bell, we'll start with you.
Stacy did a wonderful job of sort of setting the stage for us tonight on this particular topic. And so, if you think about your lives and what you experience, you think about your life course, you were born under certain conditions, you grew up, you went to school, you had social networks, you attended grade school and high school and all of those. You either went to college or worked or did whatever. You received health care in the communities that you lived in. You had people that you interacted with. If you're part of a faith community, you attended worship services and were part of lots of different social networks. And then as you got older, you probably access healthcare more often. And so when you think about social determinants of health, it's across the life course, the ways in which those things that you do impact your health. And when we think about the wonderful thing, I'm a lifelong resident of North Carolina, and one of the things I really like about North Carolina is our rich diversity. We have, racial and ethnic diversity. We have geographic diversity. We have, the second largest number of people living in rural communities of any state in the nation. And so when we think about this issue of social determinants of health, we have to think very broadly. I mean, there are lots of people whose what we call social determinants of health are quite different. I grew up in a rural tribal community in Eastern North Carolina. My experience is a lot different than someone who, grew up in the mountains of Western North Carolina. And so, when we think about these issues from a public health perspective, we have to take all of that into consideration. We have to take into consideration, what it's like for a teenage mother. We have to think in a certain community. We have to think about what it's like for that person who needs insulin and maybe can't afford to buy that insulin or store that insulin. And so it is a unique challenge, but it's one where if you look at the graph that Stacy had up, we can have the biggest impact when we focus on those social drivers, those social determinants. And people will use those terms interchangeably, social determinants or social drivers. I use both, but it is something that we in public health here in North Carolina, we have to step up to that challenge to understand, when we see communities that are not being healthy, it's not just what happens in the four walls of a health clinic. It's the entire life course.
I will just add, you did hear me say social drivers a lot, and they are used quite interchangeably. And I'll just add, I tend not to use determinants because it seems so immovable. It seems sort of like fated, right? And so I do tend to use sort of the drivers of health more because it seems like we might be able to steer that in the direction that we want it to go. So I don't know if it's the internal optimist in me or what, but you will hear me say drivers far more often. But one of the things that your question was about, they seem really invisible, and they can, and except I would contend that maybe they're not as well. And so I challenge you all, even on my drive here to Charlotte, I live in Western North Carolina and was driving from there to here tonight. And just in that drive, just taking notice of what I'm seeing, that broken windows and abandoned cars or even abandoned buildings, and then a thriving shopping center, and children playing, and even businesses and buildings, right? And I just am taking note of what are the things I see, and that in that drive, in that 2-hour drive, I'm going in and out of communities, and visually seeing these social drivers. And in that same time, as I go from one town to another, I can sort of visualize the life expectancy going up and down and up and down. So they are around you and you can see them. And so particularly for those of you who are looking at career in public health and utilizing public health, I would encourage you to be sort of observant. And that's how they're impacting little things, like those little things that we pass by every day are those social determinants, and that they are impacting people's lives to a degree that in the same county, from one end of the county line to the other, there may be a decade, years difference in how long someone will live.
And I would just add, often think of social determinants as forces, and they're forces that affect all of us. And when we think about health, one of the pieces that we often think of is, well, it's, we all want to have perfect health, right? The World Health Organization said, the absence of social, medical, or social, emotional, physical impairments. And so the other piece that I want to add to this conversation is that health is really about the ability to adapt and to cope. And for all of us, whether we are, or when we are infants, when we're small children, adolescents, throughout life, these social determinants that may be quite embedded can have differential impacts on us depending where we are in our life course. And it affects all of us, right? And so they can be forces for good. And most of these are not just happening because they're happening because of policies, because of rules and regulation, because of people's passion, but also people's indifference. And so when we think about these social determinants of health, we need to ask, why is it this way? Why are we seeing what we're seeing when we're driving down the road? Why do we feel safe in a new building, maybe with brand new carpet and new glue? We assume that the policies are there to assure that the air quality is good here, right? And so social determinants of health for me are about how do we make the healthy choice the easy choice. It's easy to be here. I don't have to worry about the carpet, right? It's easy to go to school. I don't have to worry about it because it's a good quality school. So those would be the other components I would add to the discussion.
Thank you all for the insight on social determinants. Dr. Bell, your research focuses on racial and ethnic disparities in chronic disease management. How do social determinants of health contribute to these disparities? And what are some of the systemic changes that we need to address to improve health outcomes in marginalized communities?
Yeah, so I think certainly if you look at the data for many health outcomes, unfortunately, what we see is that populations who are of a racial and ethnic, what we call a racial and ethnic minority population, they are oftentimes have higher rates of those health outcomes. And oftentimes that is persistent. So if you're looking at the infant mortality data that Stacy showed, I mean, that high number you may have not able to see, but that the line at the top was African American, and that rate has been the highest for African Americans for a long time. And so what we have to do in understanding why we see these persistent disparities in these health outcomes is to look at these social factors, to look to say when we have, so an example would be looking at the disparities in diabetes. And so thinking about a disease like diabetes, where we see, higher rates of being diagnosed with diabetes for these populations, higher rates of dying from this disease, higher rates of going blind, having your leg amputated, your kidney shutting down, all of those factors. And when you think about a disease like diabetes, you think about how complex it is to manage it well. I mean, you have to understand how to check your blood sugar and you have to understand how to eat a certain way and take your medicines a certain way. And so all of those factors then come into play as it relates to these social determinants. So can you afford the medications that you need or the test strips to check your blood sugar? Do you have the educational underpinning to understand the importance of, eating a certain way or taking your medications on a certain schedule? Do you live in a neighborhood where it's unsafe to be physically active? Do you have the resources to, do you not have a refrigerator to store your insulin? And so all of those factors come into play, and we have to understand, so what contribution these social determinants have in that disparity, in that difference in those health outcomes, but then how do we, from that point, understand how do we address those? How do we meet the challenge of stepping into that gap and trying to address those disparities?
Thank you. Stacy, as a leader in public health, what are some of the most significant social determinants of health that you've observed in North Carolina? And what are some of the initiatives that the Department of Health and Human Services are implementing to address these challenges at the state level?
So we see gaps in health. Another term I'll use in health disparities or gaps in health in almost every health issue. And social and economic drivers are extremely common. And so those are the types of gaps that are related to income and race or gender and education. And sort of in particular, when I'm thinking through it, like how much money or wealth we have impacts a lot. It impacts about where we live, what foods we can buy, what jobs, how many jobs we may have to have. And so as a public health professional, it feels really limiting to what leverage do I have to change how much money someone makes or an income level for folks. And so from a health and human services standpoint, we start to look at what are the other levers that we have. And as you heard me talk about, Medicaid expansion, while in my field, it seems really hard to be able to change someone's income level, it seems way more feasible to change eligibility of certain things to meet where folks' income levels are. And that's partly, I think what I want to sort of talk through is that the initiative that led to Medicaid expansion, which is really using that lever of access to care and saying with legislators, with Health and Human Services, with local partners, with lots of community partners too, and nonprofits, saying if we pull this lever and are able to increase the access of care, then we open up all these new doorways for the opportunities of health for folks. And so, it's fairly new, but has a lot of initial success, meaning that, prior to Medicaid expansion, I believe it was your income level was about 37%, I think 37% of the federal poverty limit was your eligibility. And that meant for a family of four, I think that's just a little over $9,000. Anything above that, you weren't eligible. And so there's a lot of people out there who are working a lot of jobs who aren't going to have that access to care, and still, based on this prior eligibility, made too much money. And so that particular lever of access, when Medicaid expansion launched, it meant changing that eligibility from about 37% of federal poverty limit to, I think it's 138%, which meant now folks, families making over $30,000 were now eligible, right? That ended up being 600,000 people enrolled. And so that's 600,000 new people who now have access to things like screenings and testing and treatment and preventive care. Again, to Dr. Mohammed's point, that trying to create policies and programming that helps make the healthy choice the easiest one. So when we move that lever and we bring that eligibility to more people, now we're helping that driver that is health behaviors become easier and no longer a hindrance. And so the folks who then become eligible are their parents who are working those 2 or 3 jobs. They're other adults who are caring also for our next generation. And so now we're caring for not only just our next generation in those children, but also the entire family unit. And that in itself starts to help create other opportunities for health for an entire family.
Thank you for sharing that. Dr. Mohammed, in your role as both within academia and healthcare, and thinking about the roles that you've had on a national level with ASPPH, can you talk a bit about how addressing social determinants of health within educational institutions and healthcare systems can help reduce health disparities, particularly for underrepresented groups?
So I want to put in a plug for ASPPH, the Association of Schools and Programs in Public Health. The workforce expert panel that I co-chaired was on transforming education in public health. And over a 3-year period, the expert panel met and then had recommendations that were vetted by hundreds. We received hundreds of public comments. And we came up with 4 recommendations. And the first one included grounding our education in the social determinants of health. And so I encourage those of you who are interested to look at ASPPH Framing the Future. There are 3 expert panel reports. And I think that what the key takeaway from those discussions that we had on social determinants of health was that it's important that we talk about them and that we learn what they are, but that's not enough. That we really have to think within our professional responsibilities, what does it mean to understand the social determinants of health? And how do we act on those? And so for clinicians, so it really is about workforce development and making sure that everyone's toolkit is really adaptable to try and partner in these collaborative efforts to change the context in which people live their lives. So for example, we need to learn how to talk about social determinants of health. If you look at, there's the Framework Institute that says using language like social determinants of health is not helpful with the general public. We need to be able to translate that. So we need to be able to talk about it as a clinician to our patients. We need to be able to talk about it as a public health professional to our colleagues, to our community members, and to those who don't believe in the power and importance of public health and those who are funding public health, right? So there are multiple layers where we in academia need to do a better job of assuring that not only our current students, but those who come into our institutions for continuing education are really grounded in the social determinants of health, because we need to partner. Nobody can do it alone. I think that's the piece that we're learning about how complex these components are. And from a healthcare perspective, I'll just briefly share the story where I learned what the social determinants of health were before, and this is 20 years ago when I was practicing in Cleveland, Ohio, was I had a patient with asthma, pediatric asthma, and I was doing everything I had been taught professionally as a family physician to take care of the asthma. And he was still, his name, I would call him Charlie. He was 7 years old. He was still having asthma exacerbations. Okay, does he have the right medicine? Does he know how to use the inhaler? Does he have a spacer? Does his mother, who was his primary caregiver, understand how to use it? Okay, still not getting better, missing school, refer him to a pediatric pulmonologist, and he gets a little better, but he's still having all of these untoward complications. And it wasn't until I did a home visit And I came, I went to the apartment and everybody say, oh, were there cockroaches? And it's like, no. Was there mold? No. It was a nice apartment in inner city Cleveland. And it wasn't until I left and I turned the corner in my car that I passed the bus depot. So everything I was trained to do was not enough. He was going to continue to be exposed. And so when we think about social determinants of health, how do we think about how can I work with a social worker to see, is there another place that he can live? But that's just addressing social needs. We're talking about trying to transform society, right? So a clinician can't change the policy on idling buses, but a physician can testify and share the knowledge of the impact that this is having. And so I think that's where healthcare, academia, public health all really need to come together to be able to advocate and translate the importance of social determinants of health to particularly policymakers.
Thank you for sharing that example. It is actually a great segue to my next question. Look into the audience. There are so many different organizations and sectors that are represented by all of us who are in the room. This is a question for all of the panelists. As we talk more about social determinants of health, can you talk a bit more about the role that you see for collaboration across different sectors? So healthcare, education, as Dr. Muhammad just mentioned, government, business, other sectors in addressing these complex issues. And if you could share some promising examples that you've seen from your own work of cross-sector partnerships that could drive real change.
Maybe I'll start. And one of the slides that I showed you tonight had that larger public health system. And if you look closely, there are a lot of players on there that are not what you might think of as traditional public health partners, right? That yes, we see our hospitals, we see community health centers, but we see school systems, we see our community colleges. We even see justice entities and even law enforcement on there as part of the public health system, and businesses and philanthropic partners. And so I'm a big believer there. The simple answer is yes, there's lots of space for collaboration. And it does take more than just governmental public health or academic public health to do this work. It actually does take the business sector and philanthropic partners. It takes all of our communities. And I'm a big, big proponent of collective impact initiatives. This is one of the most successful types of frameworks that I have ever been a part of that brings all of these different sectors together under a shared common goal, has indicators that tell us that we're meeting that goal, and the strategies are then specific to the different sectors that are a part of that work, yet still aligned to the big shared goal. And to answer the second part of your question about like real life experiences that we've had, there are numerous examples of collective impact initiatives throughout the United States, including some that are around overdose deaths and overdose prevention, some around mental health diversion. The one that I am so closely aligned to and worked in was when I was a local health director many moons ago, and in Alamance County, where we had our community health assessment. We had a local community health assessment that, for lack of a better word, was really focused on symptoms. And I don't mean that to say that these things weren't important, but they were things like diabetes and cardiovascular disease. And we moved to a community health assessment that was about social drivers. Our community health assessment priorities for that particular year were access to care, economic stability, and education. Very different than our previous community health assessments. And so public health, as I mentioned, like sometimes gets asked, like, what do you mean education is a public health priority? Because when as I mentioned in the presentation, health, wealth, and education are tightly linked. And when we make impact in one, we are likely to make impact in some others. And so that community decided education is going to be our shared goal. We are going to improve education in Alamance County. And as a result of that, there was a collective impact initiative that ended up being called Alamance Achieves, and it was a cradle to career initiative that there was a shared goal, and there were partners from across the county, from just about every sector that you can think of, around this aligned goal, and indicators like kindergarten readiness, like third grade reading, like eighth grade math, like graduation scores. And as a public health director, I never felt like I wasn't seen or a part of that work, because in each one of those education indicators were health indicators associated with them, like ACEs, like immunization rates, like teen pregnancies. And so my work, then, those strategies that were going to help us improve kindergarten readiness and improve graduation rates, those strategies were aligned and tied to my health department, just as they were aligned and tied to social services for the ones that, were specific to them. So the strategies become specific to the mission and vision of the actual partner, and they're all working toward changing these health outcomes or this education outcome so that we have improvement in the greater goal and we reach that goal. And so I think, I now work at the state, and it's been quite a while since I've been in that space. But the last time I checked, while that Cradle to Career initiative saw the same type of impact around third grade and third grade reading as many of us saw in our communities through COVID, which was a decline, they actually have started to see some increase in graduation rates. And so what I'll close by saying is that it became imperative that education was a public health issue, and it was also an economic issue, because we're growing and raising up the next generation, and we need them to be well-educated, and we need them to be healthy, because they're going to continue our communities. And so collective impact is one of those that really speaks to me when we talk about cross-sector and cross-discipline type of work.
I'll just give a few examples that come to mind that make me smile. One example, when I think about social determinants of health, is that it's at multiple levels, and that context is the primary foundation of being able to apply the social determinants of health. And so when we think about other disciplines, I think of musicians, I think of architects, I think of business folks. But one small example is a program with musicians called Lullaby for Moms. And musicians are trained to understand neonatal care and bonding, and they work one-on-one with mothers to help the mother write her own lullaby for her child. And they bring together other moms, right? So it's social cohesion, it's addressing the family unit, and ultimately in these neighborhoods can have this tremendous impact. So we need to think about musicians. We need to think about architects who in Maine are planning what to do with the green space. The town has said we have some flexibility. How do we think about this that will bring people together? It's a safe place where there are places for people who need assistance to sit, where there may be physical activity available for adolescents, but those adolescents won't be threatening to the older adults who are in that green space as well. And then I think there's a traditional piece of going to the healthcare, but driving social determinant awareness. And that's the example of foundations supporting placement of social workers in high-risk dental clinics, right? So I think there are many ways that we can begin to think about this and how we can demonstrate to funders and to philanthropy the importance of both small scale and then on the other extreme, very large scale, which I encourage people to Google and look up what happened in Indiana, where with a partnership between academia and public health and political leaders, they were able to increase public health funding at the state level by over 1,000%. It's a remarkable story for a very conservative state about how do you translate the social determinants of health, and so that it's not about disparities and inequities. It's about economic drivers for the state, or being, what does it actually look like for a state to be pro-business, and framing these social determinants of a health in a way that can mobilize people to really invest in some of these really important approaches that are needed. So there's some great articles on what happened in Indiana just in this past year.
Yeah, so collaborations are obviously very important, not just for implementation, but sustainability. I mean, you can't really sustain, despite the best evidence to support the effectiveness of an intervention without that piece that sustains that intervention or that program in a community. You're not going to be successful. And so having that community voice, having that partnership across various disciplines is so important. I mean, the example I can think of is when in 2021 we started a American Indian Cancer Partnership, and so we had representatives from the 3 comprehensive cancer centers in North Carolina at Duke, UNC, and Wake Forest. We came together and we said, hey, let's work with our tribal communities across the state. We have the largest American Indian population in the Eastern United States, so that kind of makes sense. And so we started doing this work, not realizing or not doing a good job of realizing the importance of, partnering with tribal leaders and with tribal organizations. And so the more, we did talking circles with some of our tribal communities. We have a community advisory board where we hear from Native cancer survivors. And, we were hearing people say, I live 2 hours away from a cancer center. I can't afford the medications that I need. I don't, when I try to get care, my doctor is not respectful of who I am as a Native person. And so, trying to address all those issues is so critical that, that it takes all of, just multiple people from multiple walks of life to help address this. I do want to say, I don't want to, maybe this is not the best time to say it, but I'll go ahead and say, we've been talking about the social determinants of health and health disparities. It's not an accident that these disparities are in place. We're talking about decades of systemic racism that has created structures that are part of the fabric of, where people live and the ways in which people interact with each other and the resources that people have. And so trying to address these issues, trying to uproot that systemic racism is challenging. And so thinking about, the ways in which, there are people who are struggling through that and have struggled through that through the course of their life, we have to be respectful of that. So just want to throw that out there.
For that. And thank you for highlighting the role of systemic racism and the pervasive nature of the disparities that we are all working to address.
Neil, can I comment on that?
Yes, please.
Over here. That's great. And the role of communication experts, I think, is really important. One document that may also be helpful is from the Robert Wood Johnson Foundation, talking about structural racism. And one of the interesting findings that they came up with, and I think they did 18 focus groups around the country, was that about 75% of people were willing to talk about structural racism. We often think that it's a no-go. It's a how do we go kind of question. So about a third were readily willing and understood and eager, embracing of this as a topic of discussion. but it was that critically important additional 40% that were open to talking about it. And so that's where we need to learn from our communication experts and our psychologists and all the people who understand how do we actually build connection and restore trust, because we haven't really talked about trust, and we've talked about collaboration, but trust is hard work, right? It's a process. It's not necessarily always an outcome, right? It needs to be maintained. And I think that's the other place where cross-disciplinary perspectives can really help us all out. So we're not sweating alone.
Thank you. And that's actually a great lead in to my next question, which has to do with both communication and trust. This is, again, a question to all of the panelists. Can you talk a bit about the role that North Carolina's public health officials should play in improving public health literacy, particularly when it comes to emerging health risks or misinformation? This is when, if I had the Jeopardy theme music, I'd be playing it right now.
I mean, to be honest, I mean, there are folks in Raleigh that contribute to the misinformation. So what do you do with that? So, but yeah, so I would say that in an ideal world, we would trust our public health workforce. We would, when people say that vaccines work, that would mean something. That when there is a response to a natural disaster, that it doesn't get politicized. I mean, I may get thrown out of here later, but yeah, I mean, I think unfortunately we're kind of in an environment where the stakes are even higher. That we must do our diligence to be that voice that says, this is how we make our communities healthier. This is how we, come together to address, a natural disaster or, the effects of climate change, all of those things. And so I know that like the North Carolina Institute of Medicine has a legislative fellows program where they, talk to legislators about different health issues. And I've participated in that as a speaker. I spoke about health disparities, and there some folks push back on that. Some people don't like to hear that, but so I think it's just continuing to make the case that, and some people even, some people want to hear, well, what's the economic benefit to doing this? Okay, well, there's a moral benefit, but but if you want to hear the economic benefit, we can go down that road too. But so that's what I think. We just continue to push for believing the science, believing that our public health workforce is working for in our best interest, and teaching the powers that be to do the right thing.
I don't have too much more to add except to say that, we did, COVID, coming out of COVID, we know that, that there was some loss of trust. And so one of the things in governmental public health, particularly here in North Carolina, is that we've been doing a lot around learning about what that means for folks, and have worked with some communications types of folks to understand what is that sentiment. And I think what I'll add out there is what we've learned is when they know us, they trust us. And I think what we're really getting at there is what you had just started to mention around community and trust. And that when public health is in community, we are no longer just a figurehead, we are of the community. And that's really what we're trying really hard, both local and state governmental public health, helping folks understand that we're not just folks in Raleigh or wherever, like we're your neighbors. Like I'm literally going to the same grocery store and buying milk right beside you. I'm a mom who has kids in the same school system, that this matters to me because you're my neighbor. And that's what we're finding in some of this communication, work that we're doing, is that when they know us, they trust us. And I think that really starts getting at coming outside of the walls, whether you're in a public health, clinical space, wherever you are, that coming out of those four walls and back into the community and listening and being a part of that, so that we are neighbors helping neighbors, and not strangers. So I think that's what I will add there.
In the Framing the Future report, it talked about preparing our public health workforce to more effectively be civically engaged. And what does that mean? And again, context matters, but that may mean teaching de-escalation techniques so that you can get to the point of having a conversation with that parent at the school board meeting who is yelling at you saying that you are destroying their child's life. We need to rethink, what is it to be practice ready in public health? And what does that mean to be practice ready for North Carolina versus another state? And how do we in public health and those in the workforce adapt to those changing challenges that are being faced, and work together with public health and academia to assure that we're giving the skills that people need to effectively build trust, right? Because the lessons, I believe, of COVID were that you can't counter it. You can't argue away against someone. You have to pull them in close. And you have to do that hard work of learning what is it actually that's behind that. And so learning to tap into shared values of health and well-being for all, right? There's a lot of research that says you have to calm the emotion and then connect on shared values. But that's not traditionally in the requirements for an MPH program, right? Or any of these other disciplines that we're talking about that we want to collaborate with to actually make massive changes and improvements in the social determinants of health. So I think it's incumbent on all of us, both in the workforce and those preparing the workforce, to think, what does it look like to be practice ready post-COVID and currently with this administration?
Great, thank you. I know we're sort of wrapping up in momentarily, but I did want to share a question that came from the audience. Can you talk briefly about how we move from a framework where communities are data points on our maps to one where they are the map makers of their own social transformation? Thank you to the audience member who shared that question.
Well, you said that, I can't remember exactly how you worded it, but just that when they, yeah. I mean, I think that's a really strong part of that.
I think, just to expand a little bit of, it is important that, and I say this recognizing that I just gave a presentation full of facts and figures, right? That I'm getting ready to say that it's important to remember that these aren't just data points. These literally are the people living next door to you. They're the folks. I mean, in public health, I've always said, especially when I was a local health director, it doesn't matter if you live here for 100 years, you come here just to go to school, or you visit here for just 5 seconds. While you're in these man-made constructs of state lines, you are my responsibility, right? And so I say that in that this isn't about just facts and figures. These are people. And the way that we build community is not to come in and say, we know exactly how this should be, and you should listen to us. The role of public health and Public Health 101, and for students out there, this is going to feel like, that you already know this for sure, is that our job is to assess what an issue is, identify what the problem, like identify, assess, monitor, and then identify what are the strategies that could help here. But that requires the community to be a part of that. That my facts and figures only go so far. I need to be a part of the community and say, here's what I'm seeing. Tell me what that looks like. Tell me what you need, right? And so I think there's a lot around, it feels like going back to, the basics of public health and saying, public health is about a community for a community, and we can't do this work just on our academic or our degrees alone. Like, this work has to have those voices, and not just the voices that, hey, come to the table and you're a voice, and then we're going to go and do something. It's about, what do we do as public health to say yes to the voice and then let the community lead that? Do I always need to be the leader of that as public health, or can I be a part of a community who is leading? And so I think that's what I would just add to that.
The Framing the Future, I mentioned there are 3 panels. The third one is fostering community partnerships for a healthier world. And I think one of the pieces that we need to think about is, how do we learn to ask more questions than making statements? And in these reports, there are what are called deliberative guiding questions that are meant for academics to ask themselves, leaders of schools and programs, faculty, staff, students, and community partners. And so I encourage all of us, because we're all members of some community, to look at those reports about how do we begin to acknowledge the past history of perhaps complex relationships with those who have power and those who don't. How do we begin to reframe what is it to look at a community and say, this is their education level, when you're only measuring it by completion of 8th grade or high school and not the inherent wisdom and knowledge that exists in that community? Or when we're just saying, well, look at the poverty level in this community and we measure poverty by dollars, but not looking at the richness that exists within cultures and in communities within those communities, And I think that ultimately that's how we get to greater trust, is by eating some humble pie and really thinking about, how are the power dynamics operationalizing? How do we want them to be able to operate? And ultimately, at the end of the day, I think it goes back to, Ronnie, you mentioned sustainability, right? We can do things, but if we ignore the power and we're ignoring the trust, those won't be sustainable. And if we really want to transform society, and these social determinants of health, we really need to think about sustainability and long-term partnership, community, and friendship, right?
I'm very fortunate that I get to talk to a lot of different groups in different contexts, and I can't ever remember somebody saying to me, you know what, I'm cool with not being healthy. It's all right. I'll deal with the cancer and heart disease. And I know, people want to be healthy. They want their families to be healthy. They're tired of seeing, their father or their brother dying from colon cancer at the age of 50. They want something different. They want their communities, they want their families to be healthy. And so I, as a pointy-headed academic, I can say, look, this is what I can bring to the table. You tell me what you can bring to the table, and let's work together. There's a Reverend Joyner, who's pastor of a very small African-American church right outside of Rocky Mount, North Carolina. You should look this guy up, because same situation. His congregation members dying, diabetes, heart attacks, strokes, cancer. And so he just said, I'm going to make a change here. And he is now, he was, I think 3 or 4 years ago, he was named the CNN Hero of the Year because he put into place programs for kids, programs for the adults in his church to live healthy lives, to eat. He's got this huge farm where they grow foods, healthy foods, so members of his congregation can eat healthy. They have a bee farm where they grow they make honey and produce honey. And so he's a major agent of change. I mean, people from all over the country, our School of Pharmacy, we send students there in the summer to work with him and the kids in their program. Universities all over the country are visiting him. In Canada, North Carolina, which is, there's maybe 2,000 people in Canada, North Carolina. And so we can be agents of change when we work together in that capacity.
Thank you. Thank you all for sharing your perspectives on that. We have time for one or two audience questions, I believe, maybe a few more. So any questions from the audience for our panel? Oh, okay. All right. Well, we'll start back there first. Yeah, your hand up first. Yes.
I grew up the son of an interracial couple who in 1960 could not get married in many states in the country. They were interreligious. I am my husband and I have been together for 28 years. We are interracial, interreligious. And I think this issue of do I belong? Am I safe? Go to the core of these social determinants of health. And they go to the core of understanding where our privilege may exist and where it doesn't exist in changing political climates. I don't have an answer, but it's to say that over my years of living through the HIV/AIDS epidemic and losing many friends and seeing political cruelty, right, and lack of respect for science. I think one of the key pieces is, and I said it earlier, about not sweating alone. It's finding that community, finding community across generations. So I think that's the other piece that is really important, because the collective wisdom of what younger folks can bring to the conversation and to the brainstorming of where do we go? How do I go? How do I make my next move? I think can be really helpful. I think the other piece is telling your story, right? When we look at what has happened over time in terms of how people view marginalized communities, it goes back to I am shopping in your neighborhood. I am a human being, that we can't shy away from continuing to do that. So I think it's multifactorial, but at the core is being safe, right? And taking care of yourself and figuring out who can I be in partnership, who can I be in relationship with to sustain me during these difficult times. And then when the grounding feels pretty firm, then you can rise up, right? Then you can reach out and take a trial of an action. But I think it's really important that people don't overreach before they are ready. I think that's the lesson of COVID and sort of public health leaders being thrust in positions where I'm going to do the best I can, but I'm not really ready yet, and not having a choice. I think in this climate, it behooves all of us to take that breath and to then make very deliberate choices, but not alone.
Thank you. Considering the current climate of our administration and the weaponization of certain nomenclature and being part of public health, how confident are you in your role as you communicate to communities when words like diversity may have a negative impact, words like equity may have a negative impact? How are you combating that in your current roles in this climate?
I can say for me personally, I've spent the last 3 weeks kind of in a whirlwind, and I mean to the point where our American Indian Cancer Program is called the Southeastern American Indian Cancer Health Equity Partnership. We got to change the equity word because somebody doesn't like that. I mean, first of all, I want to say to somebody, say define what health equity means. What does that mean? Let me hear you say it. Because what is the definition of health equity? You all know it. It's the highest level of health for who? Everybody. Why is that a problem? Why is it a problem that we want the highest level of health? And why is it a problem that for some people, you might have to do a little bit more to get to that highest level? So I think for me, it's partly just educating people on what those words mean. Obviously, there are mandates that you just can't avoid, but at least at the interpersonal level, it's incumbent upon me to say, I'm doing this because it's the right thing to do. So there are some workarounds. Oftentimes we talk about inclusive excellence as a way of trying to get away from the words that seem to trigger people. But at the end of the day, we can still be about that, having that same goal regardless of what we call it.
I think you all have probably learned I'm an internal processor first. I have to write down your questions and think through them a little bit. And I think, we talked about this a little bit earlier, that one of the tenets of public health is to, assess an issue, identify the public health problem, and then, work toward improving that public health issue. And gaps in health are that, and they exist in lots of forms. There are gaps in health around race, around age, around income, about rural, like urban versus rural, right? And so regardless of the words we use, I don't know that it changes the purpose and mission of public health, which is to improve health. Our, Public Health 101 is to understand the magnitude of a problem, identify the gaps in health, and start to think about the strategies to improve that. So regardless of the words, for me, it doesn't seem to change our purpose and our mission in serving our neighbors.
This is a quiz for any students. When you have the new 10 essential services of public health, beautiful rainbow circle diagram, does anybody know what the word in the center is? It's equity. It used to be research. Right? It used to be research. It's equity. I don't think that's going away. You put in from the Public Health Accreditation Board the slide that says the fundamental domains. One of them is equity. Council on Education for Public Health that accredits all public health programs. Equity is in the accreditation criteria. The Association of Schools and Programs of Public Health, a community over 100,000 faculty, staff, and students at 153 schools and programs of public health. I didn't tell you about the first report out of the Framing the Future 2030 initiative, but it is inclusive excellence, public health through an anti-racism lens. It's not going away. We may have to shift and we may have to pivot, but it's not going away. And I think the other piece to caution ourselves with, and then maybe this goes back to that idea of pausing and then choosing, is that this concept of anticipatory obedience and how what we are seeing in so many ways are people reacting prematurely and shutting things down and not pausing and waiting and seeing what the actual impact is. So I trust, my hope is that it's not going away because it's embedded in who we are in public health. And we are just going to be dancing and tap dancing and pivoting and doing all those things. But hopefully we're going to be doing all those things together.
We have time for one more question. Yeah.
My world of experience in my career is family medicine and public health. And my ears pricked up or perked up when there was mention of the business community. And it's been my struggle to try to get business community to understand public health. Their words are individualism. Their words are, this person is in the situation they're in because of their own choice. So I try to preach egalitarianism and that we've got to have a different language than rugged individualism in this country. So I'd like to hear what you all recommend as to how to engage the business community to better understand the drivers, the social drivers of health.
I'll quickly start, and I'm sure you all have other things to add, but I think Dr. Muhammad was the one who had mentioned frameworks early on. And frameworks has a lot of resources around how do we talk about health. And in particular, I've heard a lot about the bootstraps type of things. And one of the things that when we're talking about bootstraps, that it's really hard to pull up bootstraps if there are no actual laces, right? And straps to pull up. And that some of us don't even have the boots. And so I think there are some really good resources out there that take a lot of the, and I say this with great affection, the jargon that we tend to use and make it far more accessible and real. And so one of the things, I mentioned that collective impact initiative that I was a part of many moons ago, and business was a big piece of that. Philanthropic agencies were the backbone, but the business sector, including one of the very largest business one of the biggest employers in that county, were supporters of the initiative because we were able to use some of that framing around the value of education and public health for their next generation of workforce, right? That there is a business case for it, both education and public health, and that we were able to show them that, hey, investing in education means that you're going to have a competent workforce when it's time. Investing in this as a public health initiative means things like public health, like maybe they don't think about things like immunizations and the ways but it means less days absent from work. And so I think there are some really good resources out there, in particular, like with frameworks around, what it means to, those bootstraps and not having the laces, but also, how we build as a community a grid. Like right now, like particularly in this community, we talked a lot about that we've got sort of a power grid that we want to make stronger, because right now, the next generation that's going to be your workforce in these businesses or at your hospital or the next elected officials or just the next tax base, they are falling through some of these gaps in this power grid. And so we need to make that stronger, so that no matter where they are, they're going to be supported, so that we have this next generation, and that the next generation needs a powerful grid instead of a patchy one, so that it can plug in and actually like ignite, right? And so we just really focused in on sort of what those frames would be for business. And so I encourage you to look at some of that framework material, because a lot of it is public facing and can be very helpful in talking to business, not only business, but philanthropic agencies too, and other community-based organizations who don't necessarily see themselves in public health, but they are a very important part of it. So.
So that's the language that I'm trying to figure out, what's going to resonate and work with them.
Well, I just want to mention the Chamber of Commerce was and a member of the Chamber of Commerce was a co-chair for the North Carolina Institute of Medicine's Future of Public Health report. And so there might be some resources in that as well that would be helpful.
And I would just say chime in to look at the case study of Indiana, because Indiana had traditionally prided itself as being a business-friendly environment. And so to see how they were able to frame sort of many of these themes about the health of the workforce, the diversity of the workforce, opportunities to grow, entrepreneurship, et cetera, from a public health perspective.
First of all, I want to thank the panel for taking time out of your busy schedules to come and give us some educational and informative information. And Dr. Muhammad, maybe next time you come, it'll be 80 degrees.
It was shoveling yesterday, so I look forward to that.
My question is for Dr. Bell. Dr. Bell, you mentioned about the healthcare outcomes for marginalized communities, and you talked about how to meet the challenges to step in and bridge that gap. And you also mentioned about the disparities as it relates to systemic racism. My question is, how has your team looked at, or what methodologies have your team looked at to try and attempt to bridge that gap between the healthcare disparities, social determinants, and the ongoing and never-ending social justice problem of systemic racism?
Thank you for that question. I would say, that we have tried to, first of all, we have tried to understand these issues as much as possible. So not coming in with preconceived notions about why things are the way they are in certain communities. As an example, I'm a member of the Lumbee tribe, and so I have a pretty good understanding of the history of our tribe and why things are the way they are. And but there's 7 other tribes in North Carolina, and we work with all of those tribes. And I don't make assumptions about going to the Coharie tribe or the Occaneechi tribe and say, "Oh, I'm Lumbee, so I understand everything your tribe is going through." That doesn't work. So, so we have to, first of all, go through this process of being culturally respectful to listen to the community, and then understand. So, when people tell us that, that they don't eat as healthy as they used to because of the way their communities are structured, or that that they don't have access to things that would be available in other communities, that they have to drive hours to get the care that they need. Well, outside of building a new health system in their community, what's the gap? Well, you hire people from the community to be navigators, to be community health workers, to be lay health advisors, and that in a small way, but I think a significant way, helps to address that issue in a way that, we're hiring people in the community. These are folks that understand their communities. They understand some of these barriers, and so that's an important part of helping bridge that gap. I would say also, we've been really successful working with faith communities, and so to the extent that pastors and lay leaders in churches can be a part of helping us understand what the issues are in the community, but also being a part of developing those solutions, I think is very important. And so I think those are just a couple of ways where we've recognized okay, these are the way these communities are structured, and we understand why, going back decades, but also understanding that the community knows best how to address these issues, and how can we best partner with them to address these issues.
Well, thank you. And thank you to our entire panel. So can we get a round of applause for the panel, please? Thank you for joining us this evening, and want to give a special thanks to the entire team here at the Charlotte campus. You are just always so incredibly helpful and gracious in terms of organizing events here, and just we always feel so warmly welcomed here. Just want to give a special thanks to the team here, and a special thanks to our public health program team, Caitlin Barrows and Allison Hudson. Thank you both. And yeah, if you do have any additional questions for the panel, please do feel free to come up. They're here until 2 a.m. And but wish you all a great evening, and we have a lot of hard work ahead of us, but as is clear by this evening, we are all in it together, and we will get through it together. Thank you.
At this time, the drinks are still available if you guys would like to